Good evening, everybody, and welcome to our weekly Cerebrovascular and Skull-Based Symposium from the University of Miami. Another fantastic session awaits us today. This is session 26. This is our number 26. Amazing. We started back in May with the COVID. I'm Langer-Morcos, professor and co-chair of the department and director of cerebrovascular and skull-based surgery. As every week, it is my intense pleasure to have the co-directors of this course with us, Carolina Benjamin, who's my partner, assistant professor. She runs our Keynes dissection lab, and Carolina specializes in brain tumor and skull-based surgery, as well as Mike Ivan, who is Director of Research at the Brain Tumor Initiative, specializes in brain tumor, skull-base, and epilepsy surgery, as well as our two fantastic endovascular microsurgical partners, Bobby Stark and Eric Peterson. This is beautiful Miami. These are our two main hospitals at the bottom, University of Miami Hospital and Jackson Memorial Hospital. Housekeeping instructions, those of you who have not been to our sessions before, please use the Q&A box to type your questions anytime during the sessions. We usually reserve the last half hour to engage the panelists, to answer your questions, and we do answer all questions in general. We don't offer CMEs. Please share the information about our weekly sessions with your colleagues on social media if you like them. I will try to keep my all-star panel here on time with their talks today, and I might give them a 2-minute warning before the end of their talks. This is where we are today. You can see where the blue arrow is. This is what's left for us through December 17. You can access all that on our online. I'll come back to that in a second in case you're interested to read those in detail. And of course, you can watch the pre-recorded sessions at any time. Give you a teaser for next week. By the way, today is our first out of 4 successive Thursday sessions that has to do with complications, because you, the audience, wrote to me and said, why don't you put sessions on complications? That's why we're doing this. So today we're going to do open vascular surgical complications. Next week will be skull-base, a wonderful panel to discuss skull-base complications. Mike McDermott, Fred Barker, Christine Den, my colleague neurootologist here, Kaith Al-Mefti, and Ashok Astagiri. They will divvy up complications in skull-based surgery. The Wednesday weekly Miami Global Brain Tumor Symposium that Mike Ivan runs also has been very successful. And next week is Gabrielle Zada, who will talk on minimally invasive and port-based cranial tumor neurosurgery. Again, next Wednesday at 5 p.m. And this week, my colleagues in pediatric neurosurgery have started a weekly Monday session. And Toba Niazi and Heather McRae are co-director of this course, as well as John Rageb and Shelley Wang. So those of you interested in pediatrics, please join them on Monday evening, same time, 5 p.m. Many thanks to the team that makes it happen. Roberto Soazo, who's running our webinar today. Usually it's Ignacio Escalona, as well as Ingrid and Christina. Many thanks. Obviously none of that would happen without the excellent help we get from the team here at the University of Miami. Here is the link in the yellow box to go watch previous sessions you may have missed on Wednesdays or Thursday sessions. You want to contact me, feel free to do so. Our departmental Twitter, my personal Twitter, departmental Instagram, it's all on this slide. So let me introduce our it's today 4 panelists. Greg Thompson unfortunately had a last-minute emergency and will not join us. He just called me this morning. But let me start with SX-Cohen-Gadol, who I am sure all of you know, from the spectacular educational mission he's been on the last 10 years or 15 years with the Neurosurgical Atlas. Of course, Aaron is professor of neurosurgery at Indiana University, and I always thank him for the immense effort he's put in really educating the world through his high quality content in Neurosurgical Atlas, and of course all these videos, and of course his very busy vascular, tumor, and skull-based practice. Siviero Agazzi, good friend for many years, one of the few people I can chat in French to when I want to just change a little bit and go back to my mother tongue. Siviero is professor of neurosurgery, University of South Florida in Tampa. Siviero is, of course, an officer at the North American Skull-Base Society, has a very active vascular and open skull-base practice, and he will talk to us, as I'll tell you in a second, as you can see, on AVM. I forgot to mention, Aaron will give us a talk about maybe the philosophy or the definition of what a neurosurgical complication is, and he will fill in also by taking the aneurysm complication talk that Greg was supposed to do. Aaron will do double duty for us today. And Paul Camarata, my wonderful friend for many years. We've done residency together back in the days. There he was trying to cut his hair a little shorter, but I think his hand slipped and shaved it all. But he can tell you later why he did that. So that's not an example of a complication. That's an example of dedication. Paul is professor and chair of the Department of Neurosurgery, Kansas University. Spectacular vascular skull-base surgeon who has tremendous level of experience, and he's going to talk to us today about carotid endarterectomy complications. And David Langer, who is now probably more famous than any of those people that I mentioned through his Netflix fantastic success of Lenox Hill. If you haven't watched that series, you need to watch it. He's professor and chair of the neurosurgery department at Lenox Hill, at Northwell Health, and of course an entrepreneur himself. And perhaps when he comes on, he can tell you about what he's been innovating about he will join us later because he has to be in a meeting from 5 to 6. So without further ado, I will stop sharing my slides, and I'll invite Aaron to share his and talk to us about the interesting topic of what a neurosurgical complication is. It's not as easy as you might think, and I'm sure Aaron will dissect the topic for us. And your 40 minutes, Aaron, start now. Please, thank you for doing this.
Jacques, it's truly an honor, as always, to be working with this great panel and with yourself. I truly want to congratulate you, Jacques, on an immense work you have done. Somebody who is truly multidimensional as an amazing leader, an incredible educator, clinical researcher, and this collection from your institution have been groundbreaking and really transformational in the arena of virtual neurosurgical education. So I want to tell you how all of us owe to you and your department for what you have done. And we look forward to many other educational and innovative ideas from you in the near future. You asked me to discuss complication management in neurosurgery, and I always, maybe I can play my sense of humor a little bit, it's amazing I always ask to be the main speaker for major complication talks. And I always tend to tell myself, well, maybe that's because I'm honest, and I always show people my skeleton in the closet, but then for some time I think maybe it's because I have more complication than other people. Well, let's just stick with the idea that I'm just being very transparent, and I'll stick with that going forward to give myself some positive reinforcement. I do believe that I have probably been more terrible complications than anybody I know and anybody I have seen watch their videos ever. And I think the complications define the best of us. I think people who can truly manage those moments when you truly feel like this man hanging from the corner of the rock there, and really there's nowhere to go. I think, and you can deliver the final good result to the patient that differentiates us, the best of us, from the rest of us. And I think that's something that I have always thrived to reach and be able to fix any problem, any complication. Otherwise, we know that's not possible. But the cases I'll show today pretty much describe how I feel if I was hanging from this rock and fighting for my life. Obviously, all of us want to, and I hope myself that my purpose in my career has not been to serve others, or has been to serve others, but not a warning to others in terms of showing my cases. I start with this, slide because, as William Klaus mentioned, and this is so incredible, this was when surgeons were butchers, in fact, or barbers. And as you know, we didn't come from the line of physicians, we came from the line of barbers. Up to about, I think, 250 years ago, it was Royal College of Barbers, not Royal College of Surgeons in England. And this statement truly deserves the best attention in the most moments of difficult complication. And this was again discussed in 1602. Those which are masters and professors chosen to perform the like operation ought indeed to have a lion's heart, a lady's hand, an eagle, or a hawk's eye, for that it's a work of no small importance. And I think these are the qualities that are so extremely important at the time of the worst complications. All of us know great case. Anybody can do good. Anybody can look good when you do great cases, but are you going to look good when the case is really going terrible? And that's when you require a lion's heart. You just can't be affected by your emotions. You can't be focusing on your heart rate. You can't be focusing on your knee-jerk response. You have to put all of that in a corner, and you have to learn to do that. Nobody can teach you that. You have to have a lady's hand. You have to be soft. You have to be gentle. You can't force an issue with a tumor or a vertebral artery that's causing massive bleeding and the blood pressure is dropping. You can't just start, getting very aggressive quickly without thinking ahead of time. And I'll repeat that many times during this talk, is that when something terrible happens, when seconds are important, I always say, I've been here before. This is just blood. I feel pretty comfortable being in that situation, obviously, because I have been there many times before. However, I focus on not doing the first thing that comes to my mind. I wait, I think. I actually dramatically, many of my fellows tell me, is I suddenly slow down the first couple of minutes of a major disaster. And that's because I really think of every possible reaction and the result. And obviously, hawk's eye, that cannot be emphasized, how important and preventative that is. You gotta have an open mind and be able to react effectively. And that's why it's best to wait a minute or two when you have that severe complication intraoperatively, because the moment that happens, your heart rate, your emotions, your reflexes, close your eye, your operative field becomes extremely narrow, like you're changing your field of view on your microscope. That's why you have to, at that point, expand your field of vision and have a hawk's eye. So mistakes are a great educator. When one is honest, again, honesty is critical, enough to admit them and willing to learn from them. And this is something we're going to talk to you about. What is the balance of honesty? What's the balance of being able to learn without being paralyzed in the future for future cases, which is pretty often among neurosurgeons, unfortunately. So what is a complication? Complications are defined as any deviation from the normal postoperative course. That is an extremely non-specific, loaded definition that requires a lot of refinement. Currently, that's how the complication is refined. However, there is subclassification of what is a sequela. is an after effect of surgery that is inherent to the procedure. If you're removing a posterior frontal glioma, and SMA syndrome is expected. So that's not really a complication when the patient wakes up with hemiplegia. That's an expected sequelae of the surgery, and therefore I personally don't think should be discussed in M&M, although some people do. Again, as you can see, there are a lot of gray zones here. So surgery may even be executed without any complication, but still will fail. All of us know that we do that most incredible operation and everything goes well, and you're removing that giant tuberculum cell meningioma, and the nerves look great. You preserved all the vascularity. The patient wakes up blind. And if the original purpose of surgery has not been achieved, this is not a complication but failure to cure, which in that case, in this definition, is really a residual tumor from surgery, not really definition of that blindness from a tuberculum cell meningioma. So residual tumor after surgery is failure to cure. It's not a complication. And then a sequela and failure to cure should not be included in the new classification of complications. In other words, I feel complication should be defined if there is an event unexpectedly postoperatively, which was not expected from surgery, that led to a disabling revelation for the surgeon. These are new classifications of surgical complication, grade 1, 2, 3, 4, and 5. Obviously, you can see the death is obviously the ultimate, and all of those are important to remember, especially where our hospitals are keeping track of these as we go forward. Before we talk about complications, as someone who has, again, faced many, many complications, more than I ever thought I would, and probably the absolute worst complications ever possible, these have been my personal reflections. I, through the Neurosurgical Atlas, have edited over 11 years of complex cranial surgery videos of myself, and that includes 15,000 hours of video editing. So I have sat down very carefully, gone frame by frame through every procedure, 4,000 complex cranial operations, and I've understood and studied every neurosurgical movement and maneuver, and really studied them like a game plan, like a game video. You know, when you're playing football in NFL, every team reviews their video the week before of their opponent and go frame by frame. How did I do it? What did I do wrong? Why did this happen? How can I be fast and efficient? And I think through those 15,000 hours, these are things that I've learned personally. Because as you know, when you're in the heat of the surgery, it's very difficult to know what you're doing wrong. But when you watch the video aftermath and post hoc, you can see the immense amount of learning experience involved, especially in learning about complications. So what I think is most important when a massive complication happens, when I'm removing a calcified foramen magnum meningioma and the vertebral artery is avulsed, the first thing I think about is keeping our composure. I think many surgeons, the first thing they do is they start yelling and, getting upset and, blaming on somebody else that had nothing to do with the surgery. That is exactly the opposite of anyone reaction should be. Because the first thing you want to do is have an extremely solid composure. Slow down a little bit, decrease the tone of your voice that you can see in many of the Neurosurgical Atlas videos, and just think hard. And also increase the level of what I call situational awareness. What is a situational awareness? Is when you think in more of an out-of-body experience. In other words, you have your mentor just looking over your shoulders, over the microscope, and giving you guidance. You almost separate yourself as an operator to become your guide. Somebody who's not emotionally affected, but very much thoughtfully directing the procedure. That sense of what we call surgical intelligence, for one neurosurgeon to be able to monitor their own movements and react as if they have someone else of significant additional experience monitoring them, is something that is very much embedded in surgical intelligence, situational awareness, And when the surgeon is truly what we call in flow, like an athlete, like Michael Jordan, like Michael Phelps, these are athletes that when they get in flow, it's almost impossible to fight them or defend them or steal their victory. Patience, I think that's something is extremely important when you come to major complications, when time is important. Be patient. Don't have a knee-jerk reaction response. And that's something that the knee-jerk reaction uniformly causes perforator injury, additional injury to the apparent vessel, potentially massive stroke, lengthens the temporary occlusion time. And again, being patient is so critical. You have to remember, it's like being at war. Intelligence is much important for you to decrease the number of casualties. Temperament. I cannot emphasize temperament enough. I think all of us need to have a better temperament. If I would say what's most important, probably temperament is number one. You just have to have the right temperament. I always believe the best surgeons are those who have the best temperament first. Then they have the technical ability. Then they have the decision making. I think temperament is critical. Something you're born with it. It's very difficult to learn it. Experience and confidence is very important in managing complications. Obviously, if you have seen it before, it's going to be a lot easier. And having the confidence to deal with it is critical. And that's why I watch other people's video with, as much enthusiasm as possible. I'm the associate, I'm an editor-in-chief of Neurosurgical Focus Video. I watch probably more than, 60, 70 videos of surgeons a month. And I love watching other people and, how they do things and learn from them and what they did wrong. I think all of us have to increase our enthusiasm and appetite for learning from others through their videos, watching them, rather than believing we are the person who's doing everything right. Obviously, skill is critical, but I put the skill way down. So how much of technical skill you have is not actually that important as the other ones way above it. And there are other important things that we often don't talk about, and it's very controversial. And I'm going to add them just because I always believe I have a lot of transparency in what I do, and that's maybe why I'm giving the lecture today. People and surgeons really take risk and the procedures they do based on the environment. I think there is a different tolerance of surgeons to taking risks. I know surgeons who are not maybe technically very advanced, but because they're in a private institution and they're not very well monitored, they take a lot more risks and they're able to adjust their results themselves. And therefore, they're able to do things that many of us, including myself, are unable to do. Most of us, including myself, were at state hospitals or universities where every result is extremely well, carefully investigated. While there are some colleagues who are in big, neurosurgery groups in private groups, that privademics that are able to take a lot more risk than we can. So tolerance to taking risk is very variable based on the environment, their position in the group, and many other levels. And those are things that obviously are very controversial and we don't often talk about. Also remember, just because you have done many, many tumors of skull base doesn't mean you're better than the person who did 100 less tumors. In fact, I know surgeons who have repeated the same mistakes 1,000 times in doing complex cases, but I know surgeons who have done 300 or 200 of cases that are in fact significantly better. So just remember that there's a certain number of cases you have to do. You have to be able to do 100, complex AVMs or, complex skull-based meningiomas to be good, but doesn't make a difference if you have done 1,500 versus 300. That is extremely questionable. One thing that is extremely important is colleagues, mentorship. I always say to my fellows and junior faculty, always look for a position where the job gives you the best colleagues and mentorship you can get. Location and finances are not important. I had a good opportunity to have good colleagues early on, and they allowed me to take a lot of risks. And that was probably one of the most important reasons I was able to thrive in early on in my technical ability. But what I focused on early on in my career was not becoming a very finesse and choreographically planned surgeon under the microscope. I really focused early on in my career on managing complications because I believed if I build that confidence through good mentorship, colleagues, that I can manage any complication, almost any complication, that really widened my bandwidth, or I call technical bandwidth, for me to be able to take risks, do more innovative procedures, take chances while keeping the patient safe, to do new approaches and be able to innovate. I think these are critical factors that are often not discussed. And remember, as you have major complications, keep your eyes on the road ahead. There is no question the only way not to have complication is not to operate. If you have complications, it is part of the job. However, how you handle your operations and complications, and how you let your complications affect your future career is probably more important than anything else. No one should expect to have complications, but complications is part of what we do, especially in complex skull-base and tumor surgery. There's always a range of surgeons. There are surgeons who take risks, but also help a lot of patients that would have otherwise not would have been helped if they would have gone to a surgeon who was more conservative. Doesn't mean those surgeons who took risks are worse surgeons. It's just part of a normal spectrum of a very qualified, highly respected surgeon. We know people who take more risks, like I am, and I am able to help some of those patients who are otherwise not allowed to have a chance at surgery by other surgeons. But also, I expose my patients to slightly more risk, but I have to find a balance. And finding that balance is probably what defines a master surgeon. How do you learn enough to push the boundaries, but keep the patient safe? Help those that could potentially not be helped if you decrease your bandwidth of risk, but at the same time, keep some of those you're exposing to additional risk. These are some of those extreme unspoken secrets that only you can achieve through probably 1 or 2 decades of practicing high-risk cranial surgery. There is no question, there is a phenomenon of surgeons burnout. If you do complex cranial surgery, at some point, some of your results may catch up with you. And how you deal with that is something that is extremely important for a surgeon to mature, to be able to continue to be engaging, innovative, enjoy their career. And remember, all of us love to do surgery, but what is it for us to keep that passion for technical excellence? That passion requires for us to remain innovative, to be proud of what we do, and push the boundaries every day, knowing that we're doing something that nobody else does. But how to manage that risk is something that is extremely important. Jacques, if you want to comment on any of those before I go to my videos, I know that was a lot of personal reflections. How about if I give maybe, I know the major discussion would be at the end, but this is so heavy personal reflection. I thought maybe we have a minute or two. What are your thoughts to just reflect on this from the panel?
You know what I'll do? Maybe I'll ask for a brief input from Siviero and Paul, their reflections on some of what you said and their reflections about complications. Paul, does this jive with you, all the things Aaron has been saying? Do you look at it differently?
No, this is completely appropriate and really salient reflections, I think, on a career in cerebrovascular and skull-based surgery. Any of us, as Aaron said, if you don't have complications, you're a liar, or you haven't tackled the difficult cases. And I think a very important thing that I'll bring out just briefly in my talk as well is mentorship, which Aaron talked about. I mean, if you see those who have taught you you see how they handle their complications, that will rub off on you for the remainder of your career. And I think we're all blessed to have had mentors who owned their complications and dealt with them as Aaron so ably demonstrated.
One concept, you called it out of situational awareness. Also, I think it may be described by other writers as metacognition, this out-of-body experience when something disastrous is happening to you in the OR. And that what differentiates the novice from the expert. The expert can transport themselves into this calm flow zone that is like floating above your own head, looking at yourself down. That's very true. That does come with experience, and early on in your career, none of us had it. So as a novice. Siviero, any comments on the general topic? You're muted.
Thanks. Yes, I have three brief comments. First is just how you find that boundary and how you talk about that boundary. And I like to think about complication in a way that I tell my patient, if I don't take enough risk, I'm not going to help you. And if I take too much risk, I'm not going to help you either. So that they do understand this balance between, taking zero risk for me would be not doing the surgery, not taking out the tumor. And you would be that would be the lowest possible risk situation for you, but I would not be helping you. So I try to let them understand this constant balance that goes on pretty much every minute of the surgery. Every minute you have to decide, is this too much risk or is this not enough risk? So that's the first. The second one is that when I have a complication, I like to, obviously after the complication has passed, analyze and try to see if I can forgive myself. I think it's important for surgeons to be able to forgive yourself for that complication so that you can move on, because the patient the next morning doesn't really care if you had a bad day the night before. He wants you to be at your best because you are doing his surgery, and his surgery is going to end up going as well as possible. So if I like to look when a case doesn't go well, look back and says, okay, was I prepared? And if the answer is yes, well, that's good. Was I rested? Did I have all the technology that I needed, all the skills that I needed, all the information that I needed? And then finally it says, did I do this in the best interest of the patient? Was there something else that maybe distracted me? Maybe I need to finish the surgery quicker because I have something to do. So if I can answer in a way that I can forgive myself, meaning, yes, this was all in the interest of the patient. I did not put any meetings or stuff like that in the middle. I had the proper preparation. I was rested and ready for this surgery. Then I think that I can forgive myself for that complication and going to the next day's surgery, confident that, okay, I'm back. I am back at the top of my game. And the last comment is that, these patients that have the complications are the ones that need you the most. And those are the ones that are the hardest one to round on. They are the hardest one to see in your clinic because they keep on reminding you at exactly that surgery or that moment when something went wrong. But you have to understand that these patients are the ones that need you the most because they still want to believe in you. They still want to trust that you're going to get them through the complication and through these terrible things that happen to them. And so even if it's hard to face them every day, sometimes we would like to forget about the complication, just move on and just leave them behind us in that famous cemetery that René Leriche speaks about. Well, I think it's important to remember that they're also human beings, they're suffering, and so just stay close to them. So keep your complications very close to you.
Very well said, Siviero. I agree with everything you said. That's nicely said. I think, Aaron, you're ready to show us now the real stuff.
Oh, yeah.
Go ahead.
I have plenty of real stuff. Before we talk about that, I want to bring up something, Siviero, that, something that maybe I personally, we were never on the top of our game. As a neurosurgeon, I always say, there's always the call before, you have a big case, there is something with academics, research, there is family. I always say you have to be 100% no matter if you're tired. I don't think there's ever a reason because you're too tired. Obviously, you have to find ways to deal with doing surgeries very efficiently, not for that to create fatigue. But I think there is rarely I can say that, okay, I feel like I'm extremely rested today. I have nothing to worry about. I'm going to be top of my game. We have to deliver at top of our game, no matter what the situation is. I can tell you that sometimes the most difficult cases happen when you're post-call. You have been, on it 3 or 4 days of a lot of work happening academically, and now you're post-call, and suddenly a difficult case happens that you have to do, and just around 5 p.m. the most difficult situation in the OR arises. And I always say that's part of surgical intelligence. You gotta have that's part of emotional intelligence, actually, is for somebody to really have that mega cognition, to know that you are not emotionally or in every way not 100%, but you're doing this case, and how are you going to get yourself there? And that's really what makes Michael Jordan and Michael Phelps to be so extreme athletes, is because they deliver consistently. And that consistently is so extremely important. I think all of us can look amazing once in a while, but do you look amazing all the time? That is the absolute ultimate question, in my opinion. So before we go to the exciting videos that would keep everybody really awake and really feel like I'm glad I'm not doing that surgery, is I want to talk about one more element that we don't often discuss, is overcoming bad outcomes. I vividly remember I was operating about 4 years ago on a very young woman, very difficult basilar tip aneurysm. As I got through it, and I remember I was post-call, it was 6 o'clock at night. I was trying to go around and dissect the interpeduncular cisterns, and I saw blood coming toward my face without any proximal control whatsoever, as if Moses is in the Dead Sea. I felt really that Jewish moment of being in the Dead Sea, trying to see the water coming into my face. And there was no way I could get any proximal control. It was a low-lying basilar. And eventually, somehow, with God's help, I was able to get proximal control, get the aneurysm clipped. I think the temporal occlusion time was over 45 minutes. So I thought there's absolutely no way this patient will be able to wake up well. And so I walked to the patient family, and very much disappointed, telling them that the outcome is extremely poor. What happened in surgery? Obviously, it's very important to be honest with the family. You cannot blame it on the instrument. You can't blame it on the anatomy. You can't blame it on anything. What did go wrong? What happened? And we go through it with the family step by step, exactly how it happened. And I was telling them there's no chance, or a very extremely small chance, and how we should really think about, what decisions we need to make for her life. And just as I was doing that, I remember the resident was tapping me on the back and telling me something. I said, hold on a second, I'm talking to the family. So I tapping me on the back again. I continue to say, let me finish, I'll be right with you. And then I walk out of the family's room all crying, and the resident telling me, well, she woke up perfectly normal, not even with a third nerve palsy. And I think that's obviously the most important element. Is it's better be lucky than good, but never give up on the patient. No matter how bad things go, always remember there is a chance things can go well. And so when it's a bad complication during surgery, continue doing the right thing. Don't give up. Don't feel like, okay, this is terrible, bad situation, there's nothing to do. That's not your role. That's not the way you should think about it. You have to do what's right and go forward as if the patient will have a perfect outcome. And there is a challenge to strike a balance between achieving, maintaining deep sympathy for all patient families and becoming so emotionally involved that a poor outcome paralyzes us going forward. This is such in the heart of a difficult outcome. How do we do that? Mentorship, discussing with colleagues how we can do better, and not keeping that balance of empathy and the lion's heart of moving forward. Surgical intuition is something I truly believe in. Apathy, humility, sadness over what occurred in the severely bad outcome. The patient died who walked in the operating room perfectly normal. and having a cautious optimism. You just can't have a terrible outcome paralyze you. Again, as I say, keep the eyes on the road. Lessons, I just said, never give up in surgery. It ain't over until it's over, and you never know, just like in that young woman with a basilar aneurysm. Achieve a balance psychologically in which you remember prior experiences, both good and bad, and use those lessons to avoid future problems without making those, forcing yourself to make radical decisions that you wouldn't have otherwise. Just because you had a bad outcome from a foramen magnum meningioma doesn't mean that you're going to be extremely conservative in every meningioma going forward. That's just not doing the justice for your future patients. Be creative to explore novel strategies to solve long-standing problems, and know that there is a major risk involved with that. But innovation is so much in the heart of our career, and never ever stop learning from your mistakes and mistake of others. That's why, as I said, I watch many people's videos every month, and I actually ask them to send their videos and learn from them. And believe in yourself and move forward. I think all of us have to have that. Otherwise, it's going to be difficult to do anything more in neurosurgery. So let me start with the first video. Jacques, you give me the 2 minutes. This is actually a relatively small problem, but I thought I'll discuss it just so you have an idea of how to do that, because a fair number of us do extradural clinoidectomy for vascular lesions or other problems. Again, this is a very minor problem from the other ones that I'll be discussing. Jacques, would you define how much time I have left, please?
I think honestly 10 minutes, because it's 5:45, and
Okay.
we have another 60 minutes of talk. So,
Okay.
so choose whatever you can fit in 10
Okay.
minutes of complications.
Okay, let me do this one then. So this is an interesting case and really defines that kind of composure. This woman actually is the wife of one of our cardiothoracic surgeons.
Oh, Aaron, you want to do
And,
it in play mode? It's in navigator mode.
In the
Yeah.
navigated, okay, no problem. Can you see that okay now?
Yeah. Oh, yes. Is dark? Yeah, here you go.
So this was a very sort of complex aneurysm, ACOM aneurysm. Obviously, the stakes are high. It's high in every patient, but this is a wife of a colleague. And they talked about multiple balloons and stuff. So I said, let's go ahead and clip this aneurysm. And I did a small exposure here, trying to sort of push the boundaries and eyebrow incision. And this patient is extremely high functional, so we wanted to be as careful as possible. You can see the supraorbital craniotomy, the drill and bone off and flush it with the roof of the orbit. We went ahead and entered this supraorbital subfrontal area and opened the arachnoid bands. You can see the optic nerve right there. The anatomy is very simple. In this case, exposed the A1, and we went ahead and moved along the A1, find the aneurysm. Here's the A1. It's an extremely small space. You can barely get the light of the microscope in there. Here's the aneurysm dome. You can appreciate we have to remove very small amount of gyrus just to get to the neck of this aneurysm. Here's the contralateral A1 that you can see there. I put a temporary clip here. I want to stop right there. I put a temporary clip on the ipsilateral A1. However, during this procedure, because the space is so small, this temporary clip fell off, but unfortunately, I did not know that. When I was moving some of the clips in and out, probably one of them dragged on the hinge of the clip and pulled it off. And I started dissecting the neck, fighting the intensity of the aneurysm, the turgor of the aneurysm in the dome, and I ruptured the neck of the aneurysm. So you will see that I'll get in a moment of a massive bleeding in an area where I can't even bring enough light in. So you can see there's a lot of bleeding going on, and you can't really let go of your suction because the brain will swell out, because of the bleeding that happening behind you. In other words, you can't see. So I'll show that video. So here, going forward, putting the temporary clip, hear me fighting the dome of the aneurysm. You see, I can barely see enough light, and here it is. I fought the neck. The aneurysm is partially atherosclerotic. You can see the neck torn. There's blood coming the other way, contralaterally. I haven't found the A2, and I'm thinking, I can't see what's going on. What is the best solution here? I think this is the critical time when you're having the composure and thinking. You see, I'm really spending some time. I'm not tamponading anything. I'm taking my time as if nothing has happened. Just thinking, watching the blood coming my way, feeling pretty comfortable that we have to find a solution, but I don't have the solution yet. Try to coagulate the dome a little bit to gather it away from me. I don't see the contralateral A2 well. I don't know where to put the clip, but I can get out. In other words, there's so much blood coming. This is a big suction, and we have to find a way to fix the problem. All this time, I never noticed that the temporal clip was off. So as I have the suction kept there, again, I bring a clip in, and I just think that I'm going to adjust the clip as I move forward until I just grab the tear point, and I find the A2 at some point. And here you can see movement of the clip going more posteriorly until I can barely, for the first time, see the opening to the A2 as you saw a moment ago. The bleeding stops. The clip is barely covering the area where it was torn. The A2 is, here you can see the temporal clip went off, but I never noticed it until later. You can see the contralateral A2. Fluorescein angiography demonstrates good patency. And I'm going to go forward, and you can see the brain was pretty good condition because we kept our suction in there, did not let the blood just accumulate against us where we couldn't see. And this was the final result with the ACOM preserved, and this patient did extremely well. So this was just a good example, in my opinion, of limited visualization, massive blood coming out, unable to see, but keeping the composure, taking the time, thinking about what are the options, and executing based on a moment-to-moment dynamic delivery of information. Am I getting the A2? Am I not getting the A2? Is the clip too short? Is it too long? I don't have the anatomy, but I'm using the clip as a method to guide my next step. And all this time, you have that mega cognition telling you that I know you're stressed out. I know you're very worried. I know this patient could really be hurt, but remember the fact that the anatomy will guide you. And there would be, as you move more and more, even though you're never sure you're going to be able to repair the tear, there should be a moment where you're going to be past the tear, and the clip will be helping you to close the bleeding.
You know, Aaron, very nice demonstration of what happens. Of course, another way to deal with it is, I don't know if you did it, but to put the clip on the contralateral A1. And that's actually, I do this quite routinely. It's a complex aneurysm. I go find the contralateral A1, put a clip on it, because you don't want to have to go back and find it again if a problem happens. And if, you know, and then clip the ipsilateral as needed. I don't know.
I agree with you, Jack. I do the same thing. I try to go, I mean, as soon as I can get to the other side. I think it has the advantage of avoiding having to dig through the brain to find the contralateral. And also it's out of the way because it's much deeper, it's past the aneurysm. And so I think there is less risk of your instruments, the suction, the bipolar, avulsing the clip. So I do the same thing as Jack. I routinely put the clip on the other side.
No, I don't disagree with that. I think there was so much bleeding coming our way that if for me to go get that one, I have to let go of the bleeding point and then go under the aneurysm. And the tear was on the neck more cranially. Therefore, it would have been very difficult. And the blood was squirting where it was really hidden. So I thought if I do that, the brain will start swelling. That was a strategy at that time. I'm not saying that's wrong or right, but that was what I was thinking.
Many ways to handle it, just to make sure the audience, knows of all the little tricks, and there are many more, including put in cotton, in there, absorbent, a little tamponade, adenosine, lots of things. And I know, Aaron, you've used all of those things.
Right.
Aaron, show us another case, maybe 5 minutes.
Jock, you were talking about
hello, I didn't see you.
The clip on the contralateral A1.
Yes.
I do that before I do anything. If I'm
exactly. Yeah.
That's what you're alluding to. It's not during a rupture. It's you need
correct.
Just get it
if it's a complex aneurysm, correct. I go put one contralaterally, not ipsilaterally.
I agree with you.
It's actually both. I think Paul Camarata and I learned it from Roberto Heros when we were his residents many moons ago. Yeah, correct, agree. Paul? Remember that? Yeah.
Yes.
No, I think that's very unreasonable. Just the thought process was that that was the much smaller A1. And when I thought at the time I had a temporary clip on the more dominant A1, the reason I don't put a temporary clip on both A1s is I want minimize some sort
ischemia. Sure.
Minimize ischemia. I think that's critical, especially to the perforators. That I think is critical. So there was at the time. I'm not saying that's right or wrong. So I'm going to show a video will make it worth your time to listen to me this entire time. And this is really catastrophic intraoperative hemorrhage. The hemorrhage I showed you is really sort of a mild to moderate. Let's go ahead and go to the ultimate difficulty, which is this case. This is a young patient, 26-year-old, presented with this hemorrhage. And we did a quick CTA, demonstrated an aneurysm. And it most likely was a blister aneurysm of the MCA bifurcation. She came in awake and following command. She blew a pupil on the way to the OR, and she started extensor posturing. So we knew this aneurysm is extremely unstable. You can see the hemorrhage tracks into the frontal lobe. And then we went forward. I'll go ahead and go toward, this was the aneurysm. You can see sort of odd-shaped aneurysm that bled, and we went ahead and let's move forward. We started to open the dura and dissect the fissure. This is a right-sided fissure. The brain started swelling more. I have a hard time dissecting the fissure. So I went in the subfrontal area to release some CSF and get control over the carotid. Because I couldn't get control over the M1, there's no way. The brain is becoming tighter and tighter. I think there was some sort of bleeding occurring as we opened the dura. The brain was tight. My only goal was to go ahead and go subfrontal and get the carotid so I have some sort of control. As I lifted the frontal lobe, it's that moment happens with me hanging on the rock as the single image I showed you. So look at what happens. The hemorrhage is not actually coming from the sylvian fissure. Look at the absolute...
Static. Is it working for you? We have a frozen image.
I intentionally stopped it just to say what's coming. Thank you, Joe. The hemorrhage is not coming through the sylvian fissure, which I would expect. Look what happens upon lifting the frontal lobe. We'll go to the video in a second. Hear me lifting up. The frontal lobe explodes. So I have a massive hemorrhage coming through the lobe, and the brain just overwhelms the brain.
You have acid reflux talking about it, I can see.
No. So as the hemorrhage is continuing to happen, I come to the sylvian fissure, not worrying the hemorrhage at all, and dissect the fissure as the fastest way possible, trying to grab the aneurysm with the bipolar. This is through the fissure. You see the area of the aneurysm. It's amazing.
What were you doing the blood pressure, Aaron?
We asked them to decrease the pressure, but there's so much blood coming out. It's
You
all under.
How about adenosine, try adenosine just to get a shot at something?
Yeah, you know, I told the anesthesiologist we really need adenosine. At that moment, he said, "What's the dose of adenosine?" I knew we probably just better get to the fissure quickly. So you can see actually the dome where it's bleeding from. I've never seen it that clearly. You can see. So I went ahead and did a very non-discussed maneuver called grabbing the entire MCA complex with a bipolar forceps. So I have grabbed the M1, M1, M2s, everything. These are the M2s. This is the aneurysm, and I'm just holding until the blood pressure catches up. Then I put a temporary clip as somebody hold the suction on the dome on the entire complex, M1, and then dissect the M1 and move distally until this very odd-shaped aneurysm is dissected from the M2s. Then I put a fenestrate clip, it's still further bleeding happening, and then I put another one to close it. And then I remove the temporary clip, still the aneurysm bleeding after a clip on it. And then we'll go ahead and put another one to close the proximal neck of the aneurysm. And here's the final result. ICG demonstrated good exposure, good flow through the M2s. And here is the final CT scan of the patient. And this was the result of, it's the patient 3 days after surgery. As you can see, in this case, there was blood coming through the frontal lobe. The brain essentially exploded, erupted like a volcano. There was no proximal control. We didn't have access to adenosine. And we knew that based on the blood pattern in the parenchyma that this is coming from the aneurysm. We went through the fissure. We ran into something again without proximal control. We didn't lose our composure and have a knee-jerk reaction of bipolaring things and putting clips, God knows where. We used the bipolar forceps as a method to get temporary occlusion of the entire MCA complex. And then we moved from M1 to M2 and ultimately were able to get the aneurysm controlled. Obviously, this is a case that this patient most likely had a small chance of having this outcome if we had managed it differently. So I think that's a great case. I was planning to share with you my basilar pseudoaneurysm that exploded without any proximal control. And at the same time, the microscope light went out because the bulb had an issue. But if we have time at the end, I'll show that case. How's that?
That's okay. Yeah, let's see how we do. That's fantastic. We can watch these all day and learn so many other things. Thank you, Aaron, for putting double duty for me today. Why don't I invite Siviero to talk to us about AVMs and dural fistulae, and you can load your talk and unmute your microphone. Following that will be Paul, and following that, David Langer will bring us home with bypasses.
Yes. All right. I hope you all can hear me.
We can see your slides. They're in navigator mode. Perfect.
Perfect. And I see there are about 116 participants. I do recognize some name, Ali Malik. I don't know if he was faculty at USF when I was a fellow, but if that is the Ali Malik, greetings. And then I saw Mike Cicoin, Giuseppe Lanzino, great team of specialists that are listening. So I think the stakes are high today. But so my name is Agazzi. I'm from the University of South Florida, and I will just talk real quick about complications in AVM, and in particular, in this case, about dural arteriovenous fistulas. As you all know, dural arteriovenous fistula are defined by fistulas that are fed by branches of the external carotid artery of the meningeal branches. and they drain into the drainage of the internal carotid artery. And this is where the problem is located. The symptoms of dural fistula are tinnitus, headaches, and then some of them hemorrhage. And they are classified according to their venous drainage. You have two classifications, Borden and Cognard, and they all kind of rely around the same concept that if a fistula parasitizes a sinus, but it goes in the orthograde direction, it's really not a bad fistula. If it goes in the retrograde direction, if it pressures up the sinus sufficiently to drain retrogradely, it's a little bit more aggressive, but still not too worrisome. And really those fistulas become worrisome when they start parasitizing the cortical venous drainage of the brain. So the cortical veins start filling from the fistula. The risk of a benign fistula becoming aggressive is about 2%. And the morbidity of dural AV fistulas with cortical venous drainage can be quite high, with annual mortality that is up to 10%, and annual hemorrhagic risk about 8%. And interesting to me, you know, we often talk about letting AVMs cool down before operating on them. And I don't necessarily agree with that concept, but I think in particular for dural AV fistulas, one has to realize that if that cortical venous vein is so pressured up that it bled, there is a fairly high risk of that same vein rebleeding. So treating dural arteriovenous fistula that have bled before can be a little bit more of a rush than treating an AVM, for example, that has ruptured before. Now, the concept of treating this fistula, I think, revolve around three different concepts. One, the first concept is to disconnect all the corticus venous drainage, because if you can turn an aggressive fistula into a non-aggressive fistula, well, the patient is at least shielded from the risk of hemorrhage. And you can do this either with an embolization, transarterial, or clipping the cortical drain that is backfilling. Now, the other strategy would be to disconnect all of the arteries that are parasitizing the sinus, and then there is no fistula anymore. And endovascularly, this can be done with transarterial or transvenous embolization. And surgically, this is a famous skeletonization of the sinus, where you pretty much open the dura above, below, medial, lateral, until there is nothing left except that sausage of the sinus, and the fistula is gone. And obviously, finally, you can occlude the sinus, and you can just get rid of that sinus because it is parasitized by all these vessels, either by a transvenous embolization or with a ligation excision of the sinus surgically. So how do you decide between those? Well, it depends on what the sinus is doing. If the sinus is still being used, well, you cannot sacrifice the sinus. You have to find another way. If the sinus or if the cortical vein is still used, similarly, you cannot just get it out. So depending on what the dynamics of the blood flow and of the drainage of the blood from the brain is, you can define what the strategy is going to be. And this is where we're going to the example that I wanted to share with you today, which is the example of a 50-year-old male that presented with tinnitus. This is a bull, is the mascot of the University of South Florida. And this is at our Marshall Center right at the North Campus, the student center. Now it's a ghost town, obviously, but otherwise it's a pretty lively place where students like to gather. So this patient presented with this MRA that you see here. And this is a time of flight MRA. And you will see that, I need to move that you can you see my mouse moving? Yes, I think you can. Huh? So you see here that the sinus is opacifying in this time of flight, which shows that the blood flow in the sinus is not the way it should be, because it opacifies at the same time as the arteries. So we suspected a dural arteriovenous fistula around the left transverse sigmoid sinus, and the patient underwent an angiogram to better image this. And this is a view of the external carotid artery injection. And you can see here that there is a very early venous drainage into the transverse sigmoid junction by several branches of the external carotid artery that are quite exuberant. This is a close-up view of the external with a very large occipital artery here that feeds this fistula, as well as branches from the ascending pharyngeal artery, and some other branches that is a bit harder to see here, but that come also from the middle meningeal artery and that go back to the fistulous point. Now, interesting, this is an injection of the internal carotid artery. And if you look a little bit on later in the arterial phase, there is right here, you can see a area that where a branch, a tentorial branch of the internal carotid artery, probably that should be the tentorial artery of Bernasconi, is also feeding that, that vessel here, although we would expect it to come out from somewhere from here, and it's not absolutely clear in this angiogram, but there was a parasitation of the fistula by the internal carotid artery feeders as well. So our gentleman is 50 years old, has tinnitus, and has this fistula that is fed by occipital, middle meningeal, and a lot of small branches from the ascending pharyngeal, has a tentorial artery from the IC area that is also feeding the fistula. Now, the venous drainage of the brain is still through the transverse sigmoid sinus. So the left, so the ipsilateral, the left transverse sigmoid sinus still opacifies with the carotid injection, and the patient has no cortical venous drainage at all. So when we saw this fistula, we counseled the patient, and this is a benign fistula. So the risk of bleeding of this fistula is quite low. And certainly we try to talk the patient into conservative management. Now, conservative management, you know, the pressure on the neck and stuff like this, that doesn't work very often, at least not in my practice. But he did try that and came back a little bit later, really going crazy. I mean, tinnitus can make people crazy. And in particular, I think when we think that there is a treatment, there is often no treatment for tinnitus. But in this case, obviously, the tinnitus is caused by the fistula. So theoretically, there is a treatment. So there was a real plea that was made to us to treat this fistula. And he really wanted to have this fistula treated. And so we proceeded with the treatment. So we went back our three treatment strategies, like I mentioned before, and started analyzing each one of them. So is it possible to just do an arterial embolization only? Well, because of the tortuosity of the vessels that you can see here, this big occipital artery, this could be embolized, but these small little parasitizing arteries from the ascending pharyngeal would probably not be amenable to embolization. So we thought that killing this fistula with embolization only was certainly not a feasible idea. The other reason is that this would have left us with this feeder of the fistula from the tentorial artery that, once again, was not an artery that can be embolized and endovascularly accessed. And so we thought that just treating it transarterially was not feasible. The sacrifice of the transverse sigmoid sinus, in our opinion, was also not feasible because the sinus was completely patent and still feeling orthograde. So we thought that sacrificing the left transverse sigmoid sinus would have put the patient at too high of a risk of left temporal stroke. So our final strategy was really the combination strategy, to start with an arterial embolization just to try to tame down this fistula, and then proceed with skeletonization, surgical skeletonization of the transverse sigmoid junction to complete the disconnection of the fistula for those branches that were not disconnected with embolization. So that was our, now, one thing that I've learned is that I've taken some fistulas without prior embolization when they were much smaller. And I thought, well, let's not take the risk, or maybe the artery was difficult to catheterize. But I've learned that it's always good to still get every single artery embolized that can be embolized. And the reason for this is because as the main feeders are embolized, the angiogram can actually show new feeders that were not visible prior to the embolization, but that are still feeding the fistula. And so even if the strategy is surgical to just disconnect the fistula, I think that embolizing it first, even is maybe, sometimes the middle meningeal, we say, well, we're going to get it on the way in. Yes, it is correct, but sometimes embolizing the artery actually shows a new vessel in a new location that is important to realize for the surgery to be very successful. So we embolized here the occipital artery, and then we have embolized everything that we could from the ascending pharyngeal. And then we also embolized, well, I will say we, my endovascular colleagues, embolized the middle meningeal artery right there. And so what on the second stage, let me see, there we go. This is the embolization, the final results after the embolization of all the vessels. So you see there is here this nice embolization cast, onyx cast, and this is what was left, all these tiny, tiny, tiny little vessels that were coming here that were not visible otherwise. And then from the internal carotid artery, you can see that suddenly, because we have embolized most of the external, the feeder from the internal carotid artery, it actually becomes a lot more robust, and it's a real feeder of this fistula. And then I want to call your attention here to the fact that both sinuses are visible from the internal carotid artery injection, therefore confirming our working diagnosis that the sigmoid sinus was actually working and that it could not be sacrificed. So we decided to go to surgery. Now we were ready, we had embolized everything that we could, and we decided to go to surgery. So quickly, before I show you the video, we are on the left side. Okay, this is from Roton's Atlas. This is the transverse and sigmoid sinus right here that you can see on the top left. And on the bottom left, this is the same Roton's dissection, but it shows the occipital artery right there, and the muscles and the tip of the mastoid right here, and the relationship between the tip of the mastoid and the occipital artery and all these feeders. Now, this is a little bit of a cartoon of what we're trying to achieve. So our goal was pretty much to do a mastoidectomy and to completely skeletonize the sigmoid sinus and the jugular bulb and separate the sinus from the bottom of the, separate the jugular bulb from the inferior feeders and separate the sigmoid sinus from both the posterior feeders as well as the anterior feeder, pretty much doing almost like a retrolabyrinthine approach. And this is what this video is going to show right now. So again, this is a routine mastoidectomy that starts, but you will see it stops being routine fairly quickly, because as the mastoid cortex was removed, it started bleeding a little bit. And I've accelerated this video on purpose because I want to just bring in a couple of points. It became very bloody very quickly, and every single strategy to create hemostasis was used. You see the bone wax, that didn't work very well. Get the bipolar, it works a little bit, but doesn't work very well. Finally, you get the monopolar cautery to try because you're kind of desperate, and it kind of works a little bit, but doesn't really work very well. And then you have to keep on going and keep on drilling that bone. And then at some point you have much more bleeding, and then you gotta use the finger. And the finger always works well, at least to give you a little bit of time to gather your thoughts and avoiding having too much blood loss. Obviously, this is superficial surgery, this is a mastoidectomy, but we had to struggle. I mean, this was a very bloody and difficult mastoidectomy. Pretty much, we had to drill for maybe like a minute, and then get hemostasis for maybe 5 minutes, and then on and on like this. And this again after a fairly decent embolization work that we did over several sessions, or at least that we thought we did over several sessions. So it took a few hours, okay? That took quite a few hours, but finally we made it. And kudos to my neurologist, Dr. Danner. He was the one that worked for several hours, and you can see there's a lot of gel foam, flow seal, charred tissues. there's a bunch of stuff, but in the end, we're able to get that mastoidectomy. So the next step, now that we have the dura in front of the sinus, below the sinus, and then we have the temporal lobe dura, is to open the dura.
Sorry to interrupt you. Just to orient the audience, can you show them a little bit of anatomy to orient them on this video? Where is sigmoid? Where is transverse?
Right. Okay. So so if we are here, so again, so we are on the left side.
No,
so,
on the next frame is more useful, where you're cutting the dura. Just show them the sigmoid and transverse.
Okay. So well, so it's a little bit bloody. This is the dura of the temporal lobe. Where my hand is, where the knife is the dura of the temporal lobe. So the transverse sinus is right here. Can you see my mouse moving on the screen?
Yeah, exactly.
Okay, perfect. So this is the transverse sinus right here, and this is the sigmoid sinus going down right there. So sigmoid sinus, transverse sigmoid junction is right here. So at this point,
what's that bluish thing in front of the sigmoid? Isn't that just behind the cotonoid? What is that? Yeah.
This is still bone. This is still of some of the bone.
Oh, bone. Okay. All right.
This is the bone. Yeah, this is the bone of the mastoid. So we have here what in neurotologists they call the temporal plate. Okay, so this is the edge of our craniotomy right here. Okay, so they exposed our temporal lobe dura, and then we just turn a small flap from the temporal lobe dura to have exposure of a little bit of the inferior part of the posterior temporal lobe. So this is the temporal lobe dura, and we are just opening the dura right above the transverse sinus. And so here, you see, so we're opening parallel to the transverse sinus. And here, that is where we have those middle meningeal feeders that were coming through. And you can see here in the front, right there, there is a feeder that looked like it was embolized. It was a little bit darker. And underneath, we're going to see one of the draining veins of the temporal lobe right here. And then, so we keep on going very carefully, and you will see how despite embolization of the middle meningeal, we're still going to find a lot of small little vessels. Again, this is that keep on bleeding despite, you see this vessel, I don't know if it comes through very well, but it's kind of dark because it was full of onyx, and still it was bleeding. And I think it was just channels that were beside the onyx that were bleeding. And again, this is coming from anterior. So again, we're on the left side. So anterior is right here, and it's coming from the middle meningeal. So here we start seeing the temporal lobe, the posterior inferior part of the temporal lobe with, the draining veins of the temporal lobe. One of these is definitely the vein of Labé. And again, so we keep on going here and keep on opening the temporal lobe anterior, and it's always staying anterior, inferior, in the middle fossa floor. So here we have a peak supratentorially. Okay, so this is the tentorium right here. This is the temporal lobe, and this is the vein of Labé right there. And as you see, as soon as I just mobilize a little bit the temporal lobe, the tentorium still bleeds a lot. So the tentorium is very, very hypervascular. Now we knew that this is the vein of Labé, and this is why we carefully protect it so that we don't accidentally coagulate. And then we have to start coagulating that tentorium little by little and detaching the temporal lobe from the tentorium until we can completely disconnect all the vessels that are parasitizing this tentorium. And this all while preserving the vein of Labé, which, as you see, is blue, is not red. And this matches perfectly the pre-op angiogram because there was no cortical venous drainage. And I know I'm about at 19 minutes, but the video is just another 2 minutes, so we'll be on time. So you can see now that we have the tentorium exposed, and we keep on coagulating the tentorium. And again, there's these big veins that are draining into the tentorium, including the vein of Labé right here. And then we are able to take a peek. So now we have to go and open the dura inferior to the sigmoid sinus, to the transverse. So our opening, this is supratentorial, this is the transverse sinus, and this is again a cut that is parallel to the transverse sinus inferior to it. So in the posterior fossa, this is the posterior fossa dura. Okay, so we are behind, we are retrosigmoid if you want. This is the sigmoid sinus right there. And we keep on going and disconnecting everything that comes to the transverse sigmoid junction from the posterior fossa to make absolutely sure that you have a complete skeletonization of this transverse sigmoid junction where the fistula is located. Very good. So now again, we have supratentorial, vein of Labbé, infratentorial, and this is the sinus that is skeletonized. So we get an intraoperative angiogram, and unfortunately, I couldn't. The way it was filmed was kind of funny. I'm just showing this for the example. You don't have a subtracted view. But what we did is that we did an external run, and there was no feeders. But from the internal carotid artery run, that famous feeder from the tentorial artery was still present. Now, it was not very big, but it was still present. And that's where, you know, I would like to know the panelist opinion, because we went back under the microscope. And we went back under the microscope, and because we went back under the microscope, I did not have that recording. But we continued and cut the tentorium, and this is the picture. So we continued, we cut the tentorium all the way to the incisura, so that there was absolutely a complete physical disconnection between the carotid artery and our fistula. And in doing that, we were very careful to keep the vein of Labbé intact because it was draining there. And you know, this is the postoperative angio that was done in the angio suite the next day, and that shows that the fistula is gone. And this is the internal carotid artery that also shows that the fistula is gone. And this is the AP view. So we were very happy about that. But this is the post-op CT scan. And as you can see, the patient suffered a venous infarct of the posterior inferior left temporal lobe. So I think that, I don't know if it was while I was coagulating the tentorium, but he did get a venous infarct. One thing that I would like to show you here is that the sigmoid sinus on the left side does not opacify. And despite the fact that we had a patent sinus, or I would say a present sinus at surgery, I think that somehow the sinus got occluded. Somehow the sinus got thrombosed after the resection or during the resection. And that is probably what eventually caused the patient to get that stroke. Thankfully, you know, he woke up well. He was aphasic, but very minimally aphasic. And pretty much during the first post-op week, he recovered and he didn't have no long-term neural deficit. But obviously, he went back at work, and obviously we got very lucky. And there we go. Sorry, I'm 3 minutes behind, but that is the end of my presentation. And I would like to know if anybody would have stopped at the intraop angio, say that, well, there was a little bit of the tentorium still feeding, but you should have just left it there, or you have to chase it because you have to finish up, because that was the artery that was not embolizable anyway. So if we left that tentorial artery, we would not be able to treat endovascularly.
When you were showing the angiogram, maybe I'm not seeing very well because you see a lot better. I wasn't convinced this was a tentorial artery. It looked like peel parasitization, wasn't it? When you look at all the views, it didn't follow, as you said, the straight shot of the tentorium didn't come from the cavernous carotid.
I agree with you, and this is why I was puzzled. Yes, and this is why I pointed it out. It says, you know, well, it could have been a parasitation, so this would have been a mixed fistula then, a mixed dural and PL AV fistula. It is possible. I agree with you. That artery was not really coming from the carotid where the Bernasconi artery is coming from.
Right. Bobby Stark and I recently had a complex torcular fistula with, you know, more retrograde venous things. And these things happen, the parasitization and cutting the dura. I was going to ask you, do you use the lumbar drain during the surgery or no?
That's a good idea.
The reason I asked, the temporal lobe, I mean, of course, it's full because of venous things, but I, you know, I never do this type of surgery without a lumbar drain, so you don't have to fight a swollen brain. And I bet the sigmoid sinus thrombosed by the time you coagulate on both sides, the dura shrinks, the heat of the microscope, you know, I mean, as you know, in neuro-otologic procedures, I think there is a 30% incidence of quote unquote incidental asymptomatic sigmoid sinus thrombosis, just simple neuro-otologic things, let alone something like this. I don't know what my colleagues think. David Langer, any wisdom on this since regarding either the EMBO or the surgical management? You're muted, David.
Yeah, I mean, I think, you know, these have gotten, we operate in fewer of these since the onset of Onyx. And the key to these, remember, is it's really just the venous drain, the vein that you're focused on. They can look very complicated. And I think what Silveria showed is it's the access sometimes. You just get into this bleeding along. These are such high flow vessels in the dura. But, you know, I think we're doing a really good job with the majority of these with Onyx. And the ones that can't be cured are often ones that just have poor access or have, you know, a lot of tortuosity, or you just can't get your catheter close enough to get a good working position. But, you know, once you get that kind of bleeding going with these dural fistulas, it can be very challenging. Also, I didn't notice, but if you cut down the flow in that transverse sinus enough, it may be functionally occluded, meaning when you have all that the fistulous flow into the transverse sinus, sometimes you get reflux into the vena labae. And then when you take out the flow going in, it occludes. And then that vena labae theoretically could thrombose then. So it's a precarious place because it's unpredictable. And obviously angiographically, the patient had great venous collateral, but it was something about probably taking that flow away from the sinus that caused the thrombose and led to a venous infarction. I'm not sure there's much you could have done to predict that. I'm not convinced just from manipulating the vena labae.
Paul, any comments?
No, my one comment was I would venture to bet his tinnitus got better after the embolization. I mean, you know, this was a fairly aggressive procedure for what you yourself said was a relatively benign fistula. I mean, I know the guy had horrible tinnitus, and when they're beating on you to do surgery or to cure it, this clearly was the only way to do it.
Right, but I think your point is very well taken, and I don't recall exact, but say that just a partial embolization cured of his tinnitus. What do you guys feel about leaving a dural fistula partially embolized? Do you think aren't you afraid that they're going to develop even more collateral that are even less accessible to embolization because they're going to be much smaller? What is your
I think eventually that happens. You're right, but I mean, I have managed similar fistulae with judicious embolization, maybe in an older patient, you know, and they've gotten years out of it before the eventual fistula and tinnitus comes back.
Yeah, Siviero, the data from the good work of Greg Zipfel at WashU with it suggests that, I mean, yes, they should be treated in a more benign way, those the benign ones, and partial embo just to treat symptoms would be appropriate. Okay, great case. Lots of dural fistulae are a bear and sometimes difficult to completely understand. Paul, why don't you get going with the carotid complications?
All right, I'm going to go ahead and share my screen. Is that working? And can you hear me?
Very nice.
All right, yes. So we're going to change anatomical substrates here and move to the extracranial carotid artery. First of all, I want to congratulate Jacques on the Zoomposium. This really has been a phenomenal educational experience throughout the pandemic and the lockdown. So congratulations to all of your colleagues at Miami, and truly I'm honored to be in the company of these other esteemed colleagues and neurosurgeons. Jacques made an original or a comment at the beginning of my. Someone
They're two different things.
Did you guys hear that?
Oh.
Yeah, this is not from you.
It's not from me. No, somebody's unmuted.
Hold on.
Here. Okay.
Whoever is not muted, please, let's see. Is it Aaron? Aaron, can you mute your phone, please? If you can hear me, thank you.
Jacques made
That's
a comment.
me. I took care of it. Sorry.
That's all right. Showed a picture of my bald head at the beginning. David, you didn't get a chance to see that, but it was the Buzz for BAF. David and I are on the Brain Aneurysm Foundation Medical Advisory Board, and we shaved our head cue ball bald for fundraising. And I'm sure David will be quick to point out that he did outraise me at the very end. It came in after I had long forgotten about beating the bushes.
What happens is there, you get the early money, but I knew that the late money was coming in, so it all worked out.
Just like the votes, right? Just like the votes. Yeah,
that's right.
That's right. I have no disclosures, and Jacques, please give me the 2 minutes when we need to.
Sure.
Need to wrap things up. We were reminded of this earlier by Siviero, and I won't try and butcher the French here by the renowned surgeon René Lariche, but he said every surgeon carries within himself a small cemetery from where time to time he goes to pray, a place of bitterness and regret where he must look for an explanation of his failures. And in complications, this is something you really have to take heart. And I think if you don't, I think you will not be a better surgeon, that you are a better surgeon for remembering these disasters, these complications. I mean, I can remember, people, names, dates, time of the day when these complications occurred, and then the miserable angst from a horrible complication that you feel for days. I mean, it's almost like a death. I mean, he was wise to call this a cemetery, because when someone dies in your family, how you feel just absolutely horrible, and for days and then weeks, but then time passes and you don't remember them or love them any less, but you still remember that death. And that's the way that these serious complications, I think, will continue to be in your memory, or should be in your memory, if you are to learn from them and to remain empathetic. So enough of philosophy, and moving on to the carotid artery disease. With this sculpture, I'm reminded every time I see it of the Alcock maneuver, trying to talk to the residents who don't know what that is anymore, when you occlude the carotid arteries to see how the basilar circulation fills forward. This is one of the metopes, 31st on the Parthenon in Athens. Well, it's no longer there. It's in London, I think, at the British Museum, the Elgin marbles, where the British stole the Greeks' treasures. And this is one of the centaurs and the lapis. It's actually the battle between the centaurs and the lapis. And the left common carotid artery of the lapith here is being intentionally compressed by the centaur. You can see that. And similarly, he's trying to compress the right carotid artery of the centaur to make them pass out. So just remember, the other thing about complications is to keep them coming back. Someone mentioned that earlier. Have them come back to your clinic, time and time again. I mean, I will occasionally have a horrendous stroke, for instance, after a carotid endarterectomy. And, the tendency would be to just put it out of your mind, see the pit. Once they get discharged, hooray, I don't have to remember it again. But I have them coming back year after year. I had a phenomenal AVM catastrophe early in my career, one of these perfusion breakthrough cases. And this gentleman was terribly wounded, and I had him come back. I literally saw him for 25 years. I saw him annually after that, just so I could see how he was walking with this profound hemiparesis, how he grew from a young, 40-year-old man into a 65-year-old man with hemiparesis, just to constantly remind me of what could be. I'm sure many of us on this call have been to funerals of our patients or sent sympathy cards after complications. Again, I remember a woman with a basilar early on in my career that I had attempted to clip following coiling, who, you know, I was patting myself on the back for getting a eventual clip on after I tore the neck underneath the firm GDC coils, and only to have her come back 6 weeks later with a massive rupture from a pseudo aneurysm, and went to her funeral. So at any rate, about this particular slide, the greatest good you can do, this is from Benjamin Disraeli from Great Britain. It's not just to share your riches, but to reveal to him his own. I had the fortune of training with Jacques under consummate teacher and leader, Dr. Hiros, Roberto Hiros. And this quote certainly applies to him, and Steve Haynes as well, as a skull-based mentor. And I'm reminded of a day about 30 years ago when my interest in carotid surgery was really kindled when I think it was about 1990. It was a CNS meeting, I want to say Vancouver or someplace like that. And they were talking about the NASCET trial on the panel. The panel was Steve Haynes, who was, you know, evidence-based medicine guy, Robert Spetzler, I can't remember who else was on the panel. And Steve said, all right, we're enrolling our patients in the NASCET trial. Robert, you're found to have an 80% stenosis of your internal carotid artery. What would you do? Would you be randomized? And he said, I would grab a mirror and do the case. You know, jokes don't work too well on Zoom, I know, but I can sense that Jacques is
So it's very
laughing.
funny.
Yeah,
He
yes.
that to me too.
You know, and the carotid is such a beautiful operation, which those of you who have been involved in this, trainees, etc. I mean, when you see that, this is something the head and neck guys get to see every day. And we look at it, it's just a remarkably beautiful operation where you see the, you know, all of the nerves and all of the blood vessels exactly where they're supposed to be. I was trained in the halcyon days of carotids at the University of Minnesota, where we had free reign dating back to a conversation from the John Nigerian, a renowned transplant and vascular surgeon, had with Lyle French, who was the head of neurosurgery. And Nigerian said, we're going to start doing carotids here. Neurosurgery doesn't do carotids anymore. It's vascular surgery's realm. And Dr. French said, well, I think you get all of your organs from our patients. So there's going to be a little tit for tat here. So we continue to do carotids at Minnesota. I think it was at that same CNS carotid course that I heard Thor Sunt, again, remarking on, you know, the beauty of the operation and, you know, the complications that you can have that range from, you know, stroke to peripheral nerve injuries to greater auricular nerve injury. And he mentions that, you know, Thor Sunt, for those of you who don't know, is a huge proponent of neurosurgery, carotid endarterectomy. He, you know, basically trained generations of surgeons at the Mayo Clinic to do that. And he said, again, military guy, you know, back in the day, bald, real tough guy. He said, now you see this artery here, this nerve, this is the greater auricular nerve. And if you cut that, or if you stretch that, you know, ladies can't feel the earring in their earlobe. He said, but if I see a guy wearing an earring, I just cut it. Anyway, just hearkening back to the days of endarterectomy at the Mayo Clinic. So why should we ask neurosurgeons to do carotids? And Roberto gave us the best answer. I'm paraphrasing him now, is it's easier to teach a neurosurgeon how to sew up a blood vessel than it is to teach a vascular surgeon stroke neurology. And many of us will have seen, you know, vascular surgeons come by and say, we need to do this or that operation. And you look at the angiogram, you say, well, wait a minute, you don't need to do that. He's getting all of his blood flow to his brain from here. There's really nothing going through that, you know, stenotic or you know, atretic carotid after a dissection, a heel dissection, etc. So I'm going to break these complications down into just a few categories. So there are the stroke-related complications, so either ischemic or hemorrhagic. The ischemic stroke complications I would break down into the intra-op catastrophes or intra-op ischemia, which are related, I think, to vessel handling, and post-operative ischemic stroke, which is related to the dissection of the plaque. I recently had a case, you know, we're going to share our dirty laundry here of a carotid a few months ago that we're monitoring the EEG, we're monitoring the MEP SSEP, and we're getting the dissection going. And all of a sudden they say, there's no, we're losing our MEP and SEP. And I said, well, we haven't done anything. I haven't put any clips on. I'm dissecting the internal carotid. And they, raise the blood pressure, et cetera, help us out here. And no, there's nothing. We got 0. Here it is. I walk over and look at the potentials dropped. And so I quickly took over the case, just zipped through things, opened everything up. We had great back bleeding, did the endarterectomy, quickly wrapped it up, nothing. I mean, 0, we're still, and of course he wakes up completely hemiplegic. We rushed down to the angio suite, and sure as heck, he had a clot in his MCA, probably from handling or mishandling the carotid, the internal carotid. And it was fished out with a stent retriever. And although he suffered a stroke, he was able to recover walking and using his arm and hand and everything. So it turned out okay, but it just goes to show you, there are points of this operation that I thought after 30 years, I had never seen these complications that continue to happen. And I'll show you one of them here in just a moment. There's the hemorrhagic complications we're all familiar with hyperperfusion. And then there's the nerve-related complications. I mean, the nerves that are, beautifully surrounding the anatomical structures of the neck, the greater auricular nerve, sensory branches of the cervical plexus, cranial nerve 7. How do you get cranial nerve 7 in a carotid? Well, if you get your incision too close to the angle of the mandible, the marginal mandibular branch will be injured. And many of us have seen the patients, they attempt to smile afterwards and the lip doesn't go down. It's a particularly disfiguring complication. 10, 11, 12. I distinctly recall, I can tell you the guy's name right now, of a patient that came back to my office 6 weeks later and says, I'm doing great, doc, but my shoulder's just killing me. I have to take off his shirt and his trapezius is all atrophied from an accessory injury, probably from a retractor placed too deep. And then of course the wound related complications as well. Again, here the beautiful neck dissection and the things that can be injured, the hypoglossal nerve right here, the vagus nerve, down here, the accessory nerve over here, the greater auricular nerve is going to be up here, the marginal mandibular branch of the facial nerve as well. All of these at risk during a typical carotid surgery. So again, if you look at the complications in a temporal sequence, so for instance, the timing of the surgery in order, the incision planning must be done to avoid nerve injury, the dissection avoiding deep nerve injury and vessel injury, the handling of the carotid artery, which I mentioned to you, the one complication I recently had related to that, the plaque dissection, placement of a shunt. I had a case where I guarantee you I got a dissection in the proximally placed shunt in the common carotid artery. It can also happen when you place the shunt distally, which is a good reason not to use a shunt on every case. Complications of wound closure and then complications in the postoperative management of the patient. So I'm going to actually stop sharing my PowerPoint because I checked out the sharing and it actually works better if I share my QuickTime player for this movie. So are you now seeing the video beginning? Can you see that, Jacques? It says carotid complications.
Yes, we see it.
Okay, yeah, the video plays a little better in this manner. So I'm marking out the mastoid process here, the angle of the mandible. Can you see my mouse moving?
Yes.
Yes.
Okay. Okay. So the marginal mandibular branch of the facial nerve going close to the angle of the mandible. I want to stay a couple of finger breaths underneath the angle of the mandible with my incision. If I bring it too close, again, you'll get that unsightly, lip deviation when someone smiles. I also mark out the sternal notch, mark out the mastoid process, and then the incision begins along the anterior border of the sternocleidomastoid muscle. And again, I don't use this entire incision, but I mark it all out in case the plaque keeps going higher. I don't go high where the greater auricular nerve may be hiding, because I don't want to cut it or get too close and tear it. So the dissection's deepened. I use exclusively bipolar cautery. I try and avoid monopolar at all costs. In fact, I try and see how far I can go in the dissection before I actually need a section. Try and get all the way down to opening the carotid up. Again, the dissection here going along the anterior border of the sternocleidomastoid. Eventually, this person had some gels, common facial vein identified, and behind the common facial vein runs very commonly the hypoglossal nerve. We don't see it yet in this particular case, but I have gotten into problems with the hypoglossal nerve hiding just behind the common facial vein, so that when you go to tie it, you inadvertently loop the hypoglossal. And you need to see all around that common facial vein before you take it. There's the hypoglossal in this particular case. Again, here's the carotid, a little stitch I put in to rotate the carotid a bit, keeping careful eye out for the vagus.
Your voice is fading a little bit. Can you maybe get closer?
Yeah, I sure will, yeah. I usually mark the incision on the carotid because I am concerned about cutting into the bifurcation with my incision if I get too close. So I never want to get that close to the bifurcation. And then place our loops on and our clamps in the appropriate order. This was the particular arteriogram in this patient. You can see all the terrible plaque, calcified plaque along both the common carotid and up into the internal carotid. And so then I began, and again, I was taught again to maintain the plaque sort of in an aesthetically pleasing or maybe even artistic manner. You try and not cut through the plaque and simply dissect around it so that the plaque can be removed in toto. Again, this was a peculiarity, a Hirosian peculiarity, but going around and dissecting around the plaque, taking the pen-filled dissector under it and turning it at an angle so that you can then sharply cut the plaque off the origin in the common carotid. But as you saw on that CTA, this plaque goes way down into the common. You could probably chase it all the way into the arch. You don't need to do that or go down because the blood flow is in this direction. So here we begin to see one of the problems, again, which I have feared and never actually had until recently, and that is getting too deep in your dissection. Or rather too superficial. In other words, where you get to worry about going through the adventitia of the vessel. So here we are trying to get the plaque to feather out of the internal carotid artery. It's not happening, so I'm extending my arteriotomy, trying to cut the plaque out. And as I do, you'll notice when I come back here that I got way too close or too deep in dissecting the plaque out. So again, the plaque is not feathering, so I'm going up and cutting it. And now I will make a cut transverse to gradually peel out the remainder of this plaque. But that's not the problem. The problem comes later, and you'll see it'll be right under this area of the distal plaque. So that's not a good dissection. This is going to get cleaned up quite a bit. And it did get cleaned up. But then I noticed, oh my goodness, I've created a flap, sort of an intimal flap, by taking the dissection plane a little bit too deep right there. And I got nervous. I thought, how am I going to rectify this? Am I going to put a tack up in? That's certainly one option. Am I going to catch this with my closure? And it's at this point I started to believe, see there, it's like, oh my gosh, do I peel this back? No, I started to worry, did I go through the back of the artery? Am I going to have to salvage this by cutting out that segment of artery and having to do an end-to-end anastomosis? So I'm finally determining that I am going to suture that up here, but I'm also going to place I cleaned out the end a little bit more, which you don't see completely here, but then I'm going to put a patch in. I patch selectively. I patch in small carotid arteries, women who have smaller distal carotids, and where you have a chronically small artery, commonly I will patch, but usually I don't use a patch. So here you can see that little flap right there, and then a little bit later you will see I'm beginning to sew the patch in, and I actually am using a HemaShield, I believe this thing is called. There's Gore-Tex that you can also use. I am suturing it in here in the end, and you still see I missed the flap. I've actually sewed the upper portion of the patch in right here, but that flap is still present. So I took it down again and re-sewed it up so that finally this little patch was completely one with the patch on that side, and continued sewing the patch in from each end. And just a way to salvage a tactical error in dissection of the plaque in this particular case. Eventually the lesion was closed, the carotid was closed fine, placed a small piece of Surgicel and gel foam over top of it, and then after closure of the platysma, closed the skin in standard fashion. Just the last couple of slides, then we'll let's see, let's get past that video. So my current practice is that I use the operating microscope. I was not trained that way. I was trained to use loupes, but I began using the microscope a number of years ago during the dissection of the plaque, particularly the distal dissection, to avoid more of what happened there. I was using the scope in that case, however. And also for closure, I think when you close the carotid with the microscope, there is virtually no leakage. I do my carotids asleep, except in the case of severe COPD, when we do them awake and have the patient squeeze a rubber ball or something in their opposite hand. I use EEG on all cases. I selectively shunt because of the fear of dissection by passing the shunt up or down, selectively patch for the reasons I mentioned, and I use aspirin and Plavix for all cases, both pre and post-operative. I begin it 5 days before surgery, and I continue it for a month after. I think Dr. Harbaugh, very ably demonstrated in his case series of over 2,000 carotids that there were fewer ischemic complications with both aspirin and Plavix. And it's easier to take a clot out of the neck than to reverse a stroke. So I'm always going to err on the side of more antiplatelet therapy. So my changes over 30 years, I now use the microscope, dual antiplatelet pre and post-op, selective shunting, patching, tack-ups, and continued advocacy among neurologists for a neurosurgical endarterectomy.
Oh, that was very, very clear. Very nice video, very teaching. You should use it over and over to teach young people.
Jack. Yeah.
Subtleties of plaque. Absolutely. It's very rare to be able to demonstrate that. Any
Yes.
of my colleagues have comments about this?
Yeah, I use the exoscope now for all carotids. It's a great way to use the exoscope because it's a loop operation, and your head's not down. So I start right off right away with it, and also I can look up the lumen. You can drop the exoscope and stare up the lumen. I have a video of a bunch of carotids with the exoscope. It's been a remarkable benefit. It's just insane. The lighting, the visibility. Also, I also stopped doing the incision. I watched the ENT guys, head and neck surgeons. I just do like a horizontal and more of a horizontal incision. Then it's a little bit more cosmetic rather than the one right down, parallel the SCM. But that's a great look. There aren't that many videos of endarterectomies from neurosurgeons, because especially skin to skin. So that was just really terrific. And showing that flap, that can be, those flaps, and they lift up. It's how you manage them. It's always treachery, and I think you did a really nice job.
Thanks, David. We've got to get that exoscope, but many of our health systems are on lockdown as far as capital expenditures right now. So, love to have that.
David, go ahead with your talk, please. Thanks. I introduced you earlier. I'm not going to reintroduce you again. It takes too long to sing your praises.
You see my screen?
Yes.
Well, first of all, I'm not kidding. A lot of us started using Zoom around COVID. I think, Jacques, you really have really taken full advantage. I'm just the depth of the faculty and your relationships shine through, and it's an honor to be on this this time. I appreciate the opportunity, and thank you for inviting me. These are great guys, and this is the benefit of COVID, actually being able to we never would able to do this before, and it's saving us money, but giving us a lot of access, and it's really a terrific technology, and you've really blown it up. So thank you. I have to first start off by thanking the core guys at Lennox, that they've all made contributions to my personal success, and Mitch, Rafa, Jason, and John are really we're a great team. We have 3 new people that have joined us subsequent to this picture, but you know, this is a little bit nostalgic of what New York reminds me of. New York, we're all struggling like everyone else, and I just wanted to thank them for being there at this very trying time for all of us.
I never realized how short you are without shoes.
Yeah, I know. It's really, I got to put clogs on next time or something. Mitch is 6'4", so that's the problem. So I love this quote by Mike Tyson. It reminds me about bypass. You know, I think anybody who's doing bypass trains their whole life. This is a passion. It's a lifestyle. It's not a job. This is something we just love to do. It's a small group of people ultimately that really, I think, have gotten to over the years. My personal relationship with bypass was really through the Alana project, which started around 2001. That's when I got to know, you know, many of the people that are involved in bypass today. And although Alana has faded into oblivion, the relationships are left. And I think it's reflective of what failure is. There is no such thing as failure. That, you know, I look at that as a great opportunity to have met people, learned techniques, talked about things, and bypass surgery has become, I think, almost like an aspirational kind of North Star for the people who do it. And I think it continues to, you know, challenge all of us. And I really enjoyed Aaron's approach. And I think it is mind over matter, and having a great team, having partners, no jealousy, no schadenfreude. You know, those are things that are really important when you're training and when you're growing. You know, I think that when I think about complications, you can break them up in your mind. That it starts out, you know, most of the complications of bypass after you're technically good at doing this are just indication, frankly. That's why if you're going to do this operation or any neurosurgical operation or any operation in general, it's all about indication. You can live with yourself when the indication is appropriate, when you have a complication. But when you take a shortcut, when you do it because you can, not because you should, you know, there are 4 kinds of surgeries here. You shouldn't do, you can do, should do, and must do. And a bypass really has to be a must or a should operation. It's not an operation you just can do. You know, spine, there are operations you can do. There are other quality of life surgeries, but bypass is a must or a should. And you have to start thinking about indication first. And I guarantee that many of the complications that we have, particularly with ischemic, with augmentative bypass, or indication, and lack of appropriate workup, lack of understanding the physiology, lack of having the appropriate data. That's why COS and the New England Journal study failed. So the first thing is understand, what are you trying to do? Are you augmenting flow, or are you replacing flow? Fatty Charbel, who's I think one of the most thoughtful people in this field, really talk about this. And, you know, if you have to understand what your goal is, then when we talk about the technical aspects of the operation, you have graft complications, you have target artery complications, hematological complications. The graft, whether it's a single distal anastomosis like the STA alone, or whether it's a replacement vessel or a transplanted vessel, you have complications each aspect of the artery, whether it's the proximal anastomosis, the distal anastomosis, and the length of the vessel itself. And then as far as the luminal complications, the length of the graft, kinking, spasm, these all create additional complications with the actual graft. I think I always try to stick with the STA if I can, and then I work backwards. If I can't use the STA, it's STA stump. If it's not STA stump, it's IMAX. If it's not IMAX, it's neck. I think the IMAX for me has become a workhorse. It shortens your graft. It eliminates any kinking. It's much easier to size the graft. And to me, whenever I've had complications, I always try to learn from them and adjust my strategy. And I'll, talk a little bit about that. Hematological complications, we see this all the time, whether it's a clot, whether it's intraluminal clot or a subdural clot or an intraparenchymal clot. The minute you start getting clot in your graft, you give heparin. The minute you get an epidural or subdural, you stop using heparin. Heparin's all over the place. I personally don't use heparin systemically. I've used it occasionally if I have a particular STA that with a hypercoagulable patient, a lupus anticoagulant, or a young patient that's had history of hypercoagulability. If I can't keep the graft open and there's clear demand, and that's happened about a half a dozen times in my career. But I do not systemically heparinize at all. And other people do. It's just, that's my bias. I think the most important thing to remember is that the bypass surgery is a technical operation. It's just a technical thing. But the mindset of bypass is totally different. It's indication, it's preparation, it's not giving up anything. And then once the graft goes in, how you manage it from there. We all know in that bypass surgery, when you release the temporary clips, that anticipation of what that's going to look like and that Doppler flow. And you're just, when you don't get that, or it's not right, or the angiogram doesn't looks funny, or you have to take an aneurysm down, that's really when the bypass begins. And we've all been there, where you have the graft, everything looks fine, all of a sudden that something changes, or there's a change in the flow, or you go to take the aneurysm down and there doesn't seem to be enough demand. These are where the rubber hits the road. And as I go on in life and I do more and more of these things, it seems like sometimes that every case is unique, and the one outcome doesn't always affect the other. The complications are varied. These are the complications that we're most familiar with: intraparenchymal hemorrhages, ischemic stroke, hyperperfusion deficits, which can lead to bleeds, seizures, infection, and then extra, subdural, epidural hematomas. I mean, there are others, but these are the ones that indication and focusing on these different aspects of the case are the ones that you're most likely to impact. All patients I put all patients on some sort of seizure prophylaxis. Every one of my patients on aspirin preoperatively. I ensure that I have a plan, that I have an idea of what I'm going to do. And again, you never give up your options, and always be prepared for a failure. I think I've shown this slide in other talks. It's actually a real picture I took when I was in Scotland. I went to a friend of mine's 40th birthday party. She rented this mansion in Scotland. A bunch of couples were there. And we were my wife and I were driving to Loch Lomond. It pretty much rained the entire time we were there, but the sun would come in intermittently. And I'm driving on this road, and at that point, it was like 2005. I had an SLR camera. I pulled my rental car off the side of the road. I ran in the middle of the road, quickly took the picture, and jumped back in the car. And back then, we didn't have the picture right away to develop. And I came home and developed the film. And I was so focused on the rainbow that I didn't see the truck in the picture. And when I first got the picture back, I was like disappointed. I was like, oh my God, this picture's ruined. I never saw the truck. But the more I thought about it, I think this is really a metaphor for what we do, that we're all trying to be the best we can be. We're always chasing that rainbow, but there are these curves in the road and you have to handle it. And sometimes you get hit by a truck. Sometimes you get punched in the face. And truthfully, this is part of our job. It's how we, keep ourselves in line, how we keep ourselves optimistic, keep training. It goes to some of the points that Aaron said, but expect to get hit by a truck once in a while. It's going to happen. It can't not happen if you're pushing yourself and doing good work. And I think you just have to be exceedingly prepared if you're going to do bypass. And I think one of the failures very early on is finding a mentor. If you think you can do this without help, without a great team, first of all, it's not as much fun. And second of all, you're going to get hit by a lot of trucks and you may not bounce back after a while. Asking for help and eliminating your ego and giving yourself other people a chance to help you is incredibly important, because there will be failures and you're going to want somebody who has your back, who can help you get through them. I'm just going to show a couple of complications and finish. This is it's a short STA video. It's going to basically show a bypass where I get a clot. It's a 54-year-old HIV positive male, hemiplegia, right hemiplegia and speech difficult, left hemiplegia and some speech difficulty, had this chronic ischemic stroke. We do a full workup with SPECT and Diamox, showed hemispheric hypoperfusion. I'm using the exoscope for every bypass case. We do NOVA testing routinely. First things first, right off the bat, Carlos David taught me the best way to harvest an STA, and I really utilize this approach, which is basically creating a subcutaneous pocket and using the Colorado needle outside the vessel to control bleeding. I'll use the Colorado almost exclusively until I turn the skin flap. And then also I love the exoscope because I can do the entire operation from skin to skin with this magnification and with the light. I'm not putting my loops on, bringing the microscope in, start right away. Even the craniotomy, I can just put the exoscope up. And this gives you a lot more, I think you see things you don't normally see. So I'll just move this along. Craniotomy, typical craniotomy for my STA here. You can swing the exoscope underneath the bone flap and look to see that you don't injure the brain, that you instead of putting a periosteal under the skull, I'll just look under there with the exoscope to make sure that I'm not subdural somewhere. Up to the dural opening. Again, all with the exoscope. I routinely use motor evoked potential monitoring. So I'll fast forward to the bypass. I always mark the target on the artery with little ink dots. It gives me a target, so I don't rotate the vessel, and I use this back cutting knife. It's kind of like what Dr. Camarata did, marking the carotid. So I did this bypass. I do interrupteds with Tenno. I like to put a needle on one side. I learned this from watching the Japanese. This needle is basically holding the back wall back, and I just leave the needle in to protect the front wall. And then I can just do the front wall, and I just leave the needle in without sewing it, and it sort of tents the back wall away from me. So now I flip it back over, that needle's still there, I flip it over and I have that needle in position, I can just finish that side. So I went ahead and finished the graft. Final heparinization. Now you notice I'm bleeding, every limb bleeds well into the lumen. Not a great amount of flow, that's the distal aspect. Then I release the temporary on the donor. So I'm getting blood in all three limbs, which is what you like to see. Then after that, I reheparinize and then just finish up the anastomosis. So I go to recirculate, take off the distal, then this is the proximal on the middle cerebral recipient. Then I take off the donor. I have a nice pulsating graft. You can see I have a little bit of a little rotation at the level. I never cover the anastomosis with gel foam. I like to see if there's bleeding. I want to see where it's coming from. And then I saw this on the intraoperative angiogram. With the exoscope, because it didn't have ICG, I do intraoperative angiograms in everyone now. And I've learned also, I stopped doing them on STAs. I've seen graft spasm, and I started doing intraoperative angiograms again on all STA MCAs. So I saw this was basically, it was only filling distally and not proximally. And there was some clot in there. So the way to, now I wanted to, this is like milking the vessel to see if I can get this to open. I wasn't convinced that I still wasn't getting any Doppler. So I want to open the graft. And the way to open a graft, I put a temporary on, and then I'll make a horizontal cut. Chandra Sen taught me this, that making a horizontal cut like this is a much better way of opening. And so I open this up, and I'm not getting a lot of backflow. So I'm close enough that I can put the heparinized heparin needle in until I get backflow. And watch, you'll see a clot pop out. Boom. Then I immediately get backflow. And I just let it bleed. And then I can just actually close this with 2 individual stitches. And I kept it bleeding. I didn't put a temporary clip back on. But I really like, that's the way I like to open up a graft. When you want to inspect the anastomosis, this horizontal cut is the way to do it. So then I just can, it's about, I'd say, want to say 0.5 millimeter long, and I can just close with 2 separate nylons. And now the whole vessel is reopened. Now I have Doppler. Now in this case, I was happy, and instead of doing another angiogram, I just closed. And then here's the post-operative angiogram. You can see now I have a revascularization both proximally and distally. So there was basically something wrong here, and I was able to correct that by cutting the graft, heparinizing, getting that clot came back, and I had a working graft again. Just to one other problem that I will encounter. This is again Carlos's technique. I just love dissecting the graft this way. Again, I go distal to proximal, but Carlos was really the one that taught me about this. Again, all exoscope. This is you encounter a fair amount of graft spasm, and for those guys that are doing this for the early on, this is that step of putting the needle in and then flipping the graft, just leaving that alone. And that really gives you your front wall and keeps that back wall away from you, particularly with very small, thin-walled recipients, which a lot of these are. So what happens here, after we're done the anastomosis, I just recirculate. I get good flow from the recipient. I'm leaving the last stitch to tie there. Heparinize, last heparinization. And then I go to take the temp off of the donor. I'm getting no flow, 0. And this is almost certainly graft spasm. I just manipulate it, heparinize, papaverin, and then it gradually comes back. So you don't freak out when you see that. But that's why it's important to backbleed everything, because if you close your graft and then you do this, you don't really know what your problem is. So in that situation, make sure you bleed everything, and that your graft bleeds well before you recirculate, because you may not, you can get graft spasm. You want to make sure that you're going to have, that the graft is flowing before you close. It's very important. It looks ugly. You get blood all over the place. You have to reheparinize, but I think it's important to do that. 2 other complications. This is a patient who had a ruptured aneurysm. This came from an outside hospital with this. There was actually a pipeline that was in that aneurysm that had herniated into the aneurysm. And this is, I did an IMAX graft. This is the intraoperative angiogram. The MCA was filling. I was having a hard time seeing the graft, but I was happy. The flow was only 30 cc's in the OR, but it looked okay. We went down to, we went right to angio and saw this. This is a diffuse graft spasm from radial artery off an IMAX. And it was because of this, these types of problems that I converted to using the anterior tibial artery in the leg. I don't use radial artery anymore. I'm done. And in fact, when I talked to some of the cardiac surgeons, we gave verapamil. It sort of looked okay, but not great the next morning. That was the next morning. And I took the patient back, and there are these adventitial bands that can be wrapped around the radial artery. And just opening up these bands, you can actually improve. This is all we did. It was that little constriction from adventitia, and then look at what it looked like after the OR. So I just find the radial artery to be, it can be troublesome, and the anterior tibial artery is a better incision. It's great. It's really accessible for vascular surgeons, and I've converted completely to anterior tibial grafts. And it's because I just have struggled with the radial artery with spasm. The last case this is, I think, a cautionary tale. 60-year-old male with transient speech disruption. This is not indication. This is purely paying attention. He had this stroke. You can see the diffusion hits in the left hemisphere. Had this MRA. Now, the left MRA of the vert, I kind of missed it. In the MRA, I was looking at the MCA, and this was there, but I just kind of scanned it. I didn't really pay much attention. We did a spec. This just to remind me, we do spec Diamox. It's not colored, but this is the Diamox showing that the hemisphere was worse with Diamox. This is the pre-op angiogram. You can see the MCA occlusion, and the vert looked okay. That PCA on that side looked okay. We did a single run on the vertebral. This is the NOVA. You can see the left PCA flow was actually reasonable. The MCA flow on the left was 7. So there's really nothing, jumping out at me here. But on the post-op angiogram, you can see the graft, but the patient wasn't right. He was hallucinatory. He was combative. He wasn't speaking. And we thought maybe it was seizures. He was, basically throwing his covers up, but he really wasn't fluent. He was struggling. I thought it was hyperperfusion, but the graft didn't look like hyperperfusion and the angiogram. Got a CT 2 days later, and he had a big posterior temporal stroke. Took him back for the angiogram, and this is what the PCA looked like. We just didn't have a submental view of that critical stenosis, the PCA. And he basically had a posterior temporal stroke from a PCA flow problem during the surgery. It must have happened, during the temporary occlusion time. He probably suffered a PCA infarct that we didn't see in the early CT. The post-op angiogram, we didn't see that PCA area again, and yet he had the stroke. So you have to look at the other vessels, especially with moya, contralateral infarctions. You got to keep the blood pressure up. Don't just stare at your target artery. Look at everything. That's why I love the NOVA testing. That's why I don't do my own angiograms preoperatively. We're caring for human beings. And right now, I think, just to finish, this was how tight that lesion was. I've read this in other forums and other lectures, but Margaret Mead, who was an anthropologist and psychologist in the 60s and 70s, was asked what she considered to be the first sign of a civilization, a culture. And the student expected me to talk about fish or hooks or clay pots or grinding stones, fire, art on the walls. But no, Mead said that the first sign of civilization in an ancient culture was a healed femoral fracture. And she explained that in the animal kingdom, if you break your leg, you die. You cannot run from danger. You're meat for prowling beasts. That no animal survives a broken leg long enough for the bone to heal. That a broken femur that's healed is proof that someone's taken the time to stay with the person who's fallen, bound up the wound, carried the person to safety, and tended the person to recovery. Helping someone through difficulty is where civilization starts, said Mead. We are at our best when we serve others. Being a neurosurgeon is a privilege. Wear a goddamn mask. Care for other people. And in the end, I think we'll all get through this. And I think as a bypass surgeon, as a vascular neurosurgeon, we are blessed to be able to do these amazing operations. And I congratulate Jacques for bringing this group together, and I'm honored to be here. Thanks so much.
Well, that was terrific, as expected. I mean, we can talk for hours about each one of those talks. That was terrific, David, putting those bypass issues and there are so many variations on the theme. You're right. Let me see. Carolina, you still with us? Maybe Carolina left. I'm not sure. Let's see. Let's tackle some of the questions from the audience. Let's see. Okay, question for Aaron. Thank you for an amazing, this is Dr. Ziman Bieda. Thank you for an amazing work. Do you provide any tips for learning the situation awareness in other way than gaining experience in the OR? He wants a shortcut. Give him a shortcut so he can become an expert without putting the years. How would you like to respond to that?
No, that's an extremely good question, Jacques. I have an executive coach. Executive coach, that means for past few years, every month, I meet with someone who has executive experience and coaches, CEOs, athletes, and other people in terms of mental toughness, situational awareness, and other reasons. Something that unfortunately we haven't really dived into. It's a complete lecture of its own. That gives you an idea how to respond under stress, how to have what we call gravitas. I think you know about that, executive power, executive presence, how to be able to manage yourself under severe stress, or be able to really appreciate what you mean by emotional intelligence. All of that doesn't really provide you situational awareness in the operating room, but it's as close as you can get in terms of like an athlete, be able to manage yourself under stress.
Okay. Siviero, question for you from Dr. Lucas McGuinness. Siviero, why not to occlude the transverse sinus during embolization and close the case completely during endovascular procedure? I guess you answered that. He's saying, why not? Well, you said, go ahead and answer him.
Because it was open. I mean, I thought the patient needed that sinus. Sorry, because it was not flowing retrograde, it was flowing orthograde. That was my assumption.
Okay. Dr. Joe Rivas, I assume he's asking Dr. Paul Camarata, discuss the present surgical use of Plavix in terms of indications and contraindications and in between situations, as well as length of therapy. I guess he's asking about Plavix. Paul, you said for all carotids.
Yeah, I use Plavix pre and post-operatively for all carotids. I don't check for sensitivity to Plavix. I suppose I could. Some people may not be, but for 15 or 20 years, I did carotids with only an aspirin. So anyway, I use both of them, again, on the basis of Bob Harbaugh's excellent personal experience.
David, I have a question for you. I mean, like you, I guess you do your STAs, you leave the cuff around the STA except at the tips. I used to do that, and I guess I still do it sometimes, but as you mentioned, many times you have hidden adventitial bands, fascial bands that are stenosing it. And I guess the flow, when we measure the flow, we know. So now most of the time, the entire STA is naked, so I can actually see it. Is it king?
So you dissect along the whole thing?
Yeah, the whole thing. Now, sometimes you have to be careful. I mean, if you're too rough with it, you can create tiny micro dissections inside, but I still prefer to actually see it well without the bands. Because I've had many times with, using the flow measurements, gee, this is not so good. Then you go and you tease a few bands that are hidden, and then it opens it up. I said, I'm just going to do it the whole time. So
yeah, it's kind of like, it's feast or famine, these things. I usually, as long as I can see the artery on that kind of tissue, I think you got to see the artery. That's, I think, the point.
Correct. That's the point.
Covered in shit.
Right.
But I also agree, that also the more you manipulate it, the more likely you are to injure it or cause spasm. And so, you really have to decide what side you're on. I think certainly if there's the beauty of an intraoperative angiogram is if you have a problem, you can address it and then go back and find the area narrowing or know that it's spasm and know, especially in an augmentative operation, you can live with it a little bit as opposed to if you're, taking an aneurysm down where you need full flow right away.
Yeah, agree.
The other thing I would offer to Aaron, I found that just breathing, just literally, I literally meditate before a case and I just breathe. It doesn't take I don't do it for half an hour. And then, when I start if things aren't going well, I do the same thing. I'll stop for a second and, just take a deep breath. It works great. It's just this mindfulness and this kind of getting into the present. And Fatty used to say, you make yourself a sharp arrow, you sharpen your tip, we all work our asses off to make, technically, we learn as much as we can, make sure your shaft is smooth and your arrows are in the right spot, but you shoot yourself off, you shoot the bow and you're not on target every time. It is what it is. I think it's so true of bypass. You have to know that you're as good as you possibly can be. That's all you can do. And when something bad goes wrong, you can those negative thoughts, just breathe. And then go make yourself better next time.
Yeah, Yeah. So we've watched you on that wonderful show on Netflix, and I can see how you talk to your patients pre-op. Let me ask you, have you canceled cases on the morning of surgery because you didn't feel right on that day, David?
I actually just did last week. Not frequently. Usually it's because I see something on the film that I didn't see something, or I just don't feel right about it. I think I've done it like 3 times in my career,
Right.
but I just did one literally last week. And as I've gotten older, I care less about it. It's the kind of thing that when it's all the as a youth, you're afraid of what people are going to think, or what, oh my God, I'm not going to appear like I know what I'm doing. I don't, at this point, you kind of move to a point where you don't need that anymore. And that's what part of growing up is. That's the beauty of our business. You get, your ego diminishes as your knowledge goes up. And, I think that that's why our field is so great. You only get more and more confident and less proud and more humble as you go along. And it's a wonderful experience.
Well, you're in good company. Yazargil told me he's done it many times. Even Yazargil, he has to feel right. He's canceled. He told me many cases over the years. When we used to teach, in St. Louis courses, I've had many fun conversations with him. I actually skipped a question from Dr. Nigel Mendoza, I guess, who remembers me from the UK days 30 years ago. Nigel, if you're still on, good to hear from you. He has a question, interesting question. As an experienced surgeon, it would be expected one might have fewer catastrophic complications. Have my colleagues become more concerned about the ability to deal with such events? That's interesting. So let me ask the panelists, are you more or less worried today than you were 15, 20 years ago about your ability to deal with the catastrophic complication? Paul, Camarata, I'm going to ask you to answer this first.
Yeah, I would say that the more experienced with complications you get, the less concerned about your ability to deal with them. I mean, again, you still have the occasional complication that you've never experienced before, but I think I am less apprehensive about them now than I was 25 years ago.
Jacques, I'm going to add something. I always say the career of a neurosurgeon is like a flight you take from here to, let's say, Miami. You have the first 10 years, you're ascending and can get turbulent. The second 10 years, you're going to be in a cruising altitude where you feel you're most empowered and able to manage complications. And the last 10 years of your career, you're going to descend and you're going to have some turbulence. So you have to decide for yourself which one of those stages of flight you're in.
Well, you know what? Let me ask the perfect person, Carolina or Benjamin, my much younger partner. She's now, a year and a bit into her practice with us. Well, Carolina, tell us how you think of complications. The old geezers like us forgot how we used to think. How do you think about surgical complications at this stage in your career? You must be closer to probably the audience in general, so in age.
Yeah. Thank you so much. This has been such a fantastic talk, and everybody, give me one second.
No, you're muted. Oh.
So it's really been fantastic to hear about this. One thing that really resonated with me was I think Dr. Cohen-Gadol, you were mentioning temperament, and I think as a neurosurgeon, that's critical. And I do think partially it's that you're sort of, it's inherent, and then sort of that you develop that with time. I think for me as a young person starting out in skull base, I'm always thinking about a case in terms of what's the worst thing that can happen in this case, and if it does happen, can I manage it, and how do I manage it? And I think the most important thing is like obviously having yourself prepared anatomically, studying the images back and front, and taking the time to stop and say, okay, have I thought about all of the possible scenarios, and have I thought of a plan for each of those scenarios? And then I think in the worst case scenario, and this is really sort of why I chose coming to University of Miami, is having the mentor. And I think Dr. Morcos, for me, you've been tremendous. You know, I've asked you a few times already, hey, I'm going to do this case. There's a couple steps of the way that if you don't mind backing me up. And I think for the audience members, I think that's probably the most important thing, is go to a place where you feel supported, go to a place where you feel like your senior mentor wants you to succeed. And put, you know, humility is the most important. Put the arrogance completely aside, put the patient first, and don't be scared to ask for backup. The tricky part with that is, obviously, I could tell all of my patients that Dr. Morcos can do this infinitely better. So where do you push your limits? And I think that's where having that really great relationship of, I can do this case and I know I'm prepared to take this next step, but I do have the appropriate preparation in case I do run into trouble.
I would also offer, I think it's our responsibility at this point to do that. You know, we didn't see that in the generation ahead of us as much, at least I didn't, you know. I think then people didn't talk about it the way at that back then. This is incredibly important. And not only that, but I must say that as I've gotten older, I've got not more scared, but more aware of the bad things that can happen. And I'm much more conservative. Like, I'm not going to, you know, I feel pain. I know what that feels like. And so your threshold to do what might have been creative or innovative or risky before is gets higher. But by the same token, I feel more confident that I can do things. So they're both going up at the same time. So, and that, you have to pass that on, and you have to have a junior person that can benefit from that, because you can help that person accelerate through that part. But then theoretically, if you see us behave and you see us the way we approach the problem, then you can basically become that too. And that's, I think, remarkably important, because I don't think our field did a lot of that when we were training. I really don't.
Be careful with the use of word conservative, Dave. Dave.
Okay, anything else? Any panelist wants to say anything else? Otherwise, it's such a spectacular session. It's 7:33 p.m. and I need to let people go to their homes and dinners or whatever time of the we are. Well, thank you so much. This has been tremendous. Thank you for the audience, for sticking with us. As you can see, I have excellent taste in speakers, and each one of them gave a spectacular talk. Thank you, my friend.
Tell Greg, I hope Greg's okay. Is he okay?
Yeah, he's okay.
Yeah.
He's okay. He was busy. Thank you. Thank you.
All right.
Bye, everybody.
Thank you,
Hey, Jacques, thank you very much.
everybody. Take care. Bye-bye.
Good job.